Hello, everybody. Thank you all for attending. And now we have the pleasure to invite our first speaker. Do you want to introduce him? Maybe introduce ourselves? Oh, good idea. I'm Valeria Campos, dermatologist from Brazil.
I'm Dr. Tess Ferraris from the Philippines. So I'm going to introduce Professor Go, a famous dermatologist from Singapore, the laser guy. So he's going to talk on, is picosecond laser superior to nanosecond laser in skin rejuvenation?
Thank you very much, Sita. Good, af- good morning or good afternoon now. Now it's 12:04, so good afternoon. Good afternoon, ladies and gentlemen. I want to thank IMCAS for inviting me to give this lecture. And there are many people who've been asking me, I have a nanosecond laser, should I upgrade myself to a picosecond laser? I say it depends on what you want to do. So I'm going to give some pros and cons about picosecond lasers, and you can decide later on whether you want to invest in it, you want to spend your money or go for a good holiday. And we know that we use the picosecond laser or nanosecond lasers as a Q-switch laser to treat pigmentary disorder because of thermal relaxation time. And we usually treat them for those conditions, as you can see, lentigines, Hori's nevus, a lot of tattoos, nevus of Ota, and some other pigmentary disorders. Some of them are not treatable, as you all know, and therefore it doesn't mean that all can be treated. But with the advance of the science and development from nanosecond laser, we have now graduated into developing picosecond lasers, and we are able to have very short pulse duration, which are very good for pigmentary lesions. So the question then is that, do you want to upgrade to buy a more expensive laser? Because the picosecond lasers is almost double the price of the nanosecond lasers, and there's maintenance in addition to that. And so the controversy is that how do I enlarge the screen here? Very small. Can't even see. So the question then is a nanosecond laser and a picosecond laser is which is more cost effective? Can you enlarge the screen here? This one, yeah. Ah, great, good, thanks. Whether it's cost effective or not, the question then is what we are using this picosecond laser for. And most of the time we use it to treat benign pigmentary disorder. We use to treat tattoos. And there's no question about it that the picosecond laser is superior to the nanosecond laser when treating tattoos, all right? Because you require less treatment, and it's less painful and it's more effective. Another advantage that the picosecond laser try to promote is that you can use it for skin rejuvenation by setting the refractive lens style of effect, and you can then get skin rejuvenation at the same time. But the question that you want to ask is that if you want to buy and you want to upgrade, you want to spend double the amount of money, does it expand or extend your scope of the treatment that you have? In other words, I've got a pigment laser. Do I now can treat more things if I buy this laser? If I'm treating the same thing again, then it makes no sense to you that you're going to get any gain away. And is there any disease or conditions that Q-switch laser or the nanosecond laser cannot do that picosecond lasers can do? Is there such a phenomenon that we are talking about? Does it clear benign pigmentary disorder more efficiently? And some of them do, like for example tattoo. Does it cause less downtime? Yes, to a certain extent it does cause some downtime. I'll show you some publications. As far as we are concerned, we usually try to divide our pigmentary disorder into epidermal, dermal, or mixed. And it actually has got certain connotation in the sense that the wavelength of energy that we use, the pulse duration that we use, affects the treatment outcome of the condition. And there are many conditions here. Those in red are not treatable, all right? And this is in the days of our Q-switch NDX lasers. Those on the black one are treatable. So if you look at it, is there anything that picosecond laser can treat in the red segment? Now, can I treat Becker's nevus, so segmental lentigines, melasma, I can't. I mean, even if I've acquired the picosecond laser, I'm not going to do those things that is going to be successful with those which do Q-switch lasers that do not respond. So because second laser does improve efficiency in some conditions, but not all conditions. And in nevus of Ota, for example, nanosecond lasers, we usually treat 8 to 10 treatment to get very good result. But with the picosecond lasers, you can actually reduce it to 5 to 6, but you still need multiple treatment. And as far as treatment of lentigens is concerned, as laser toning is concerned, that if you believe in using laser to treat melasma, it doesn't make any difference at all. Your lentigens still respond to pico or nanosecond lasers. And in terms of downtime and the risk of PIH, picosecond seems to have less. But you know we have problems with 532 nanometer wavelength and the nanosecond laser because it causes a lot of PIH. And we thought that when picosecond laser was introduced, we could use the 532 in picosecond without PIH, but it's not true. I'll show you some pictures later on. That it causes a lot of PIH as well, and we can't even use it to treat lentigens in Asian skin. So there's a number of comparative studies, but these comparative studies are not head-to-head randomized control study. They are just collection of all the patients that were treated with the picosecond lasers and say, okay, they have improved. So there's no question that picosecond lasers, like nanosecond lasers, actually improve in the treatment of pigment tree disorder. And in fact, there's this report here that shows that it has got a PIH rate of 4.8%, slightly lower than that of the nanosecond lasers, and that they actually has got the same treatment outcome for some of the common skin pigment tree disorder like lentigens and cafe au lait that don't respond to treatment as well. So they follow a very similar pattern to the nanosecond laser. Then the question is that do you want to buy it or not? There's another study here to compare the Alexandrite 755 nanometer picosecond lasers, and you can see the bottom in red, 84% receiving nanosecond lasers treatment and 50% receiving picosecond lasers felt satisfied with their treatment. In other words, if you are treating simple conditions, especially superficial pigmentation, there's no difference at all. You still get the same type of outcome, and then in fact, some of the studies show that the nanosecond lasers give better outcome than picosecond lasers. And this is another study that shows that picosecond lasers in the Asian skin is a retrospective studies, and the conclusion is that for some of the conditions, you can help clearance faster, achieve clearance faster by the picosecond lasers when treating dermal pigmentary condition. In other words, if you have a dermal condition, then the picosecond will be superior. So, for example, the Horis nevus is definitely more superior than nanosecond laser because you are treating nevus of Ota. Same thing, you will get less number of treatment. The outcome will be slightly better in terms of the pigmentary reduction. So anything that's dermal, including tattoos, will have much advantage in the sense that you reduce the number of treatment, reduce the pain, improve compliance. So this is if you have the extra money that you want to invest in, this is the advantage that you are going to get. And here's another study of comparing 532 nanosecond lasers with the Q-switch lasers for the treatment of solar lentigen in Asian. And based on the cost effectiveness studies again, the nanosecond lasers is still more cost effective in terms of cost of treatment. So unless you have a very big volume and you have a lot of patients to treat, especially non-Asian darker skin type, then you find that the picosecond will be advantageous to you. So when you compare, again, there's another study by Douglas Wu, and then they compare the bilateral nevus of Ota like Macula's, which is Horis nevus. You can see that this is the dermal lesion, and then you can see that in terms of this clearance, it is better than the nanosecond lasers or the Q-switch lasers. So for Horis nevus, for example, if you have a lot of Horis nevus, yes, it's very good. It clears faster, less painful, and more effective generally. So you can buy that if you have a lot of Horis nevus. And here's another study that shows that Horis nevus that was treated, and you can see that actually there's some improvement compared to those that are treated with the nanosecond lasers or the Q-switch lasers. And there are many other studies that compare dermal pigmentary disorder. And again, the safety in terms of side effects and all that, it shows that picosecond lasers is more effective in some aspect, and that the treatment of dermal pigmentary condition in Asian will minimize post-inflammatory hyperpigmentation. So it also clears faster. So the constant information is that it clears faster, it clears only some of them, it's effective especially against the dermal pigmentation. When you come to superficial pigmentation, which we normally treat like lentigens, then it has got no advantage at all. So nevus of aorta is very good. If you have a lot of nevus of aorta, you can invest in this machine because it clears faster, it got less painful and easier to treat. And if you come to superficial lesions like cafe olea macules, Becker's nevus, no difference at all. We have to try and treat a number of patients. They all recur. They get post-inflammatory hyperpigmentation like nanosecond lasers, so there's no advantage. So if you have a lot of these patients, then it's no point getting a picosecond laser just to treat this condition. And this is the post-inflammatory pigmentation I was telling you about. 532, we know when we use the picosecond, the nanosecond lasers to treat any pigmentary disorders, nevus of aorta or what have you, we tend to get post-inflammatory hyperpigmentation with 532 nanometer. But if you treat Caucasian, you've got no problem. But you treat Asian like this patient here, we use the picosecond 532, thinking that you will never cause so much post-inflammatory pigmentation. You can see that in the second picture, there's a marked darkening after 1 month, and you get erythema rather than a frosting that you see normally with the nanosecond laser. So there's no advantage as compared to nanosecond lasers. And there was a report about using lasers, but using the diffractive optics that will improve that. We have tried some of this, and we have not come across any good result at all. And we don't think it is the treatment for melasma at all. So this is a diffractive lens that it comes with the new picosecond lasers. So in conclusion, picosecond is good for benign lesions. At least if it's effective, like the dermal lesions, you would require less number of treatment, lower downtime, and the less risk of PIH. There is no increase in the range of the type of conditions that you can treat, and therefore there is no. So you can decide on yourself whether you have a lot of money. If you have a lot of money, fine. You can invest in it and buy it. Or if you want to oblige your patient, then you can do that. Thank you very much.
Thank you for the wonderful. He has to go.
No, I've got to fly off, so I can't be around. I'm going on.
He's leaving.
Is there any
Does
question?
anyone? Should we ask a question before?
Yes, sure.
Any question because he has to leave?
Anyone?
Do you know, I have a comment. I enjoy your talks
No,
very much. I have the same impression. Like, I really feel the difference for treatment of melasma when I use the picosecond laser, and for rejuvenation. Then I think it's worth buying it.
Yeah.
But for another pigmentary, you just need more sessions.
Yeah, that's right.
Yeah,
So,
exactly.
but there's a lot of hypes about it because now everybody that comes to you, to your clinic, says, I want Pico, I want Pico, I want Pico. Because everybody has been brainwashed to say there is something new, something better. So it becomes commercialized now.
Thank you very much. Now,
So,
you have a question. Yeah.
Sure.
Thank you for your wonderful lecture. I want to ask you, can we use the 532 nanometer picosecond laser for picotoning?
Pico toning. I think we are very scared of 532, Asian people. So once you use 532, any inflammation that follows it, you will get PIH, up to 40 to 50%. And because of that, we dare not use the 532. So with the picosecond 532, we thought that it would be better. But we use it on a number of patients, and we have the same problem. We have PIH. It's very high risk of developing PIH.
Even if we use very low flows, is it safe?
We have never tried 532 for laser toning.
But why would you do that? The 1064 is safer for. I'm from South America.
Yeah.
I do the picotone, but I just use the 532 when I want like remove something. For the Tony, I think the 1064 makes much more sense because it can go a little deeper and it's safer. Not Katia? Ooh la la! Wait for the next talk.
Doctor, one last.
Dr. Guo, thanks for your wonderful talk. And
Thank
my
you.
question is, do you use any topical agent or ointment after pigmented treatment, like
Do I
ointment?
do I use any ointment?
Yes.
The usual thing, usually you get them to moisturize the skin in the first 2-3 days, and once it's settled, we start to put back all the regimen, sunscreen, and then if the patient is prone to pigmentation, we give them prophylactic hydroquinone or one of the skin whitening agent. But there's no study to show that by giving skin whitener before or after any procedures that you reduce the incidence of PIH. But we all give, I mean,
Do you think topical ointment is useful for prevent PIH?
I don't think there's any scientific study to confirm that, although we all do that all the time. So all my patients with melasma who comes from some procedures and all, I would just prescribe for them to prevent, to tell them, you know, you get risk of PIH. But if I look up literature, I can't find it. There's no study. Somebody must do the study there. Can you use prophylactic depigmentation cream when you're treating laser conditions or for various skin disorder? I don't know whether anyone has any experience there.
And my talk is about the topical agent.
Sorry?
When is your talk?
Yeah, it's
Oh, good. When is it? Okay. So you stay here. So
Okay.
thank you so
Professor,
much.
I have one last question.
Sure.
Yeah, because I don't have Pico, I only have Q-switch.
Yes.
And how many treatments is needed for the nevus of Otatu?
Well, it depends on the degree of pigmentation. If it is very dark, then you need more treatment. And generally, at least 8 to 10 treatment. And some people, some of my patients, the darker one, they have to go up to 20 treatment even.
Is it normal? 3 treatments you don't see effect yet?
Yes, the first few treatment, when the pigments, all the melanocytes and melanophages are destroyed, they will get dispersed actually. It's just like treating all pigmentary disorder.
So
You get dispersed and you look a bit hazy and it sort of get lighter but more diffuse. You see.
how many treatments before you see the
At least 3
little bit?
treatment.
Okay.
Minimum 3 treatment. So I will tell them, the first 3 treatment, you don't see result, you may get worse. And then after the 3rd or 4th treatment, you should start seeing lightening. And then after that, from then onward, you'll be lightening until your 10 or 15 treatment.
And do you increase the fluence every
Yes.
session?
Yes. If the patient can tolerate it and there's no PIH, then we will increase by half a juice or 1 juice and then see whether the patient can tolerate it.
Okay. Thank you very much.
Thank you.
Have a safe trip.
Thank you.
Thank you very much.
Thank you.
Great talk. And now I have the pleasure to my friend Cartier, who is going to show us a dragon fire. I like this. Nitroplasma technology.
Yes, it's a grant. Grants that mean we try at IMCAS session when we put grant on stage to avoid any, we have a conflict because I use this laser, but how my colleagues, we use many laser, but to try to give some scientific data, okay? It's not a symposium. Symposia is quite different. So it was funny for me to speak about the dragon fire because I'm a laserist and neogas plasma is not a laser. So you need to change your brain on why a dragon fire you will understand very quick because the society is in Wales and you know the whales it's a dragon, okay? So I say it's completely normal to highlight this device and to put the picture of this dragon. So when you use a laser at IMCAS, most of the time is to prove that you have an efficiency for rejuvenation, anti-aging, to stimulate matrix, collagen remodeling. And I say to this factory, can you prove something in clinical indication? So what's about nitrogen plasma? You know, it's fire. It's the fourth test of matter is created by ionizing pure nitrogen gas, and you have a radio frequency to induce this plasma. So it's not really new because energies exist more than 15 years, 20, 20 years. But be aware, nitrogen plasma is not PRP, it's not blood plasma, it's not plasma pain, it's not light and laser. It's quite different, and you have to change your brain. And you will see what you induce. For somebody who wants to understand, you induce a thermal effect, but you can go further. Okay, it's really easy because you have not really target, you have not wavelength, but really you have a wavelength. You have a spectrum band in between 300 until 8 nanometers, because you know any light source induce some wavelength. And you know, just to see you that you can regenerate, you can remove seborrheic wart, cerebral keratosis. It's easy because you know in my office we don't have cryotherapy. So it could be interesting to use. We can remove by laser, by ablative laser. We can use rejuvenation by other laser, but it was interesting to use this non-laser, this plasma. About the temperature, it's interesting because they calculate about the increased temperature, and you see if you want, you can reach very high energy if necessary, but it's even it's a dragon fire, it's not to burn the skin. The science is not to burn the skin, okay? So it's not only a pure thermal effect. It's very important to understand that. So you have a lot of indication for wrinkle, for skin toning, for skin stimulating, for skin tone, for pore size, for wrinkle. Okay, so about the damaging on modification skin tissue, it's interesting. It's not in TZ, you know, for laserists, we speak a lot of microthermal zone. Now it's a zone of thermal damage. And this is interesting because more you increase the energy or more you stack, you make a stacking mode, more you increase thermal effect and you have a diffusion of the heat. So it could be interesting, and they prove, and we prove by biopsy, and we will see after, that you can reach different part of the skin. You can stay like an epidemic effect, sub-epidemic effect, dermal effect, and deep dermal effect. So for seborrheic keratosis, you don't induce no scar, either you increase the thermal on the skin, and you will see you remove easy. It's unnecessary to remove with gauze. You shoot on the keratosis and you wait, and they felt alone without any problem. You have just some inflammation like laser or cryotherapy, but no more. So it's easy and really easy to do that, and you can compare to other technology if you want. About the skin tone, it works very well. You can remove and reduce some wrinkle, pore size, many things. So it's not so difficult and interesting, but you don't see any target. It's unnecessary to focus, but if you shoot more time on the target, on dark spot, it will remove as any laser. So it's funny to use, not so complicated, but you have to, the tip and tricks, that mean in this kind of situation, you can protect the epidermal if you apply a gel. If you remove the gel, you can induce some light superficial epidermolysis. So it means, do you want to apply a light gel, like for ultrasonography, a light gel before you treat or not? It depends what you want. If you want to stimulate dermis, you apply gel. If you want to have an effect on epidermal layer, you remove gel without gel. So it works very easy, and you can treat also some rosacea because you reinforce the dermal junction. You can reduce also some superficial vascular pattern like telangiectasia. So it's not a coagulation, you just reinforce the dermal junction. And you can whitening the skin. You have some side effect if you make a stacking mode, some dark spots, you know, so it's completely normal, but it's not induce epidermolysis. You need to manage exactly for the scar, the same, because you have a plasma toning, exactly the same indication from you see from scar, 3 prestige, and energy 0.8 in June, October, because where I live in north of France, really about the sun, we don't care. We just to protect, to avoid any pH. I ask my patient to put 1 month before any treatment sun cream to reduce the signal. About regeneration, you prove that what's happened about the skin architecture, the skin texture, you prove that you increase the epidermic size, and the same for about collagen in the dermis, you increase on your new collagen is very classic. About my purpose today is that you treat some patient and you see something. You try to reduce some wrinkle, you can try to reduce some laxity of the skin, but after a few sessions, you will see something different. You reduce actinic keratosis. And it was very interesting. And after the discussion with the laboratory, I say, if you want to prove something in aesthetic, try to prove something in clinical derm. So if you can prove that, that means maybe you are efficient. And we do first clinical trials, observational study, prospective study about this kind of situation. You have this kind of actinic keratosis, grade 3, and what's after? I do some local anesthesia because it's painful in this case, because we use a high energy around between 2 to 4 joules, and you will see after 3 months what happened. About the actinic keratosis, because you are derm, if you are here on your derm, you can see we have many possibilities to treat, and you have different stages about actinic keratosis, 1, 2, 3, and maybe after that is a carcinoma. And you have a lot of possibility, options, cryotherapy, FUDIX, other conversion PDT. We do that in my daily practice. We prescribe a lot of PDT, daylight PDT, CO2, we mix with different. But with the plasma, it could be interesting that can we prove something and to have exactly the same effect. What we do, we treat this patient, and in my office we do dermoscopy, but we do also LCOCT. It's a digital biopsy. So to prove something, we treat the patient, we take a picture with a video dermoscopy, and we take a picture with LCOCT to compare before and after. Before, just to give a graduation to the actinic keratosis, and at the end, for the follow-up, to see if we really cure the actinic keratosis. Because clinically, superficially, maybe you say it works. But LCOCT, because it's like a digital biopsy, you can probe. And digital biopsy is less intrusive than classic biopsy. And for just actinic keratosis, it was so interesting. And we introduce a lot of patients before and after with dermoscopy, and we prove LCOCT, and we have many patients. You will see clinically it works very well. After only 1 session, 3 joules, 5 shots simultaneously, and you will see just after some lack of cross by dermoscopy what's happened, and you will see 3 months after what's happened. You cure, and you prove that by LCOCT. Another patient, you will see it's really efficient, and you will see, and you could prove by clinically and by the different procedure. So it was not very interesting, and I was very enthusiastic about this device for that, because you can use for rejuvenation, but you can use also for, because derm has a clinical indication too. So we can prove on between different graduations, and we try to estimate and to evaluate. It was the most difficult, how to set the setting about this device. So we need to use 0.5 joules, 0.8, 1 joule, 3 joules, until the maximum is 4 joules. And it was the most important and most difficulty. And you will see about this patient, you reduce actinic keratosis, you reduce seborrheic keratosis, but you will see the skin toning, and you see some different about this thing. Because I don't treat only some lesion, but I treat the forehead and the temple zone. And you step by step, you will see the difference of the skin toning. Patient was happen okay for the actinic keratosis, because I believe that, like PDT, because we do a lot of PDT, is unnecessary. Like when you use cryotherapy to treat only what you see with your eyes, you need to treat the field of actinic keratosis, most important. And you will see the result. We focus on, we take a picture with dermoscopy and by LCT to see the difference, but we treat the full forehead for this patient. And you will see another, you look at the quality of this temporal area, you will see reduced actinic keratosis between one graduation 1 to 2, but you will see after the treatment, you will see you rejuvenate the skin, and you prove that by video dermoscopy and also OCT. And you will see the patient look at the quality of the skin after the treatment. So it was really interesting because your patient are enthusiastic after the result, even if in some cases you need to inject lidocaine to reduce the pain, because in this case, we use 4 joules, so it's painful because you increase a temperature more than 70 degrees. So it's important, but you will see after a few sessions, most of time for grade 3, we need 3 sessions, but most of time it will work very, very, very interesting. So for me, for my small sample, we say that for graduation 1, the setting is 0.5 to 1.5 joule is enough, and you don't accumulate some energy. That means you can make a stacking, but less than 10 joules. For graduation 2 is less than 15 joules. And for grade 3, just before the carcinoma, is more, maximum for me is 20 joules. No need to accumulate more energy, because the risk is to burn the skin. We are not there. We have to secure the patient, not to induce some complications. And we are now around 50 keratosis in evaluation, and we have a follow-up between 2 months to 6 months, and we will show you maybe try to publish the final result in the future. So for me, nitrogenous is not indication just for rejuvenation. It's also interesting for dermatology to treat a field of actinic keratosis like other technologies. So if you don't have the possibility to do LCOCT, to do PDT, or to prescribe local chemotherapy, plasma could be very interesting. So thank you for this first result of these devices I use now since more than 2 years. Thanks a lot. I'm waiting for you for IMCAS China in 2 months.
Thank you so much. Wonderful. Does anyone has a question for Cartier?
What level of success are you having in terms of clearance of those lesions?
The follow-up for patient now 6 months. So really it's interesting, but even the patients are old, so we know that you have some recurrence, but they have to put some sun cream to reduce the recurrence of any actinic keratosis. It's likely any other procedure like PDT, delayed PDT, normal classic PDT, or full face of after CO2, but it could be interesting for the future. Maybe can we prevent aging skin? Can we prevent scar? Because more and more we know that when we use now laser, any laser, we can prevent some skin cancer. It's very interesting for the future. So probably, why not plasma, this dragonfire, maybe can prevent aging and to avoid any skin cancer, because now it's very common in where I live in north of France.
It's very promising. You're talking about cryotherapy. I used to use it, but I don't use anymore because there's so much hypopigmentation after. And I think this looks much better.
Yeah, I stopped to use cryotherapy more than 15 years ago.
Yeah,
more than 15 years ago.
Because of not lack of results, but more because of the
like,
side effects.
I don't like cryotherapy because it's not really precise. You have to spray 1 minute, 30 seconds, 50 seconds. So with plasma, or when I use CO2 to destroy actinic keratosis, when I do PDT, it works very well. But with plasma, I know that for actinic keratosis for grade 1, switch out 1 joule. Tac, tac, tac. That's it. It's enough. It's enough.
But you need nitrogen,
Looking
right?
forward
So
to try
for me,
this,
it's more
yes.
precise. Okay.
Yeah, it looks.
I want to be
To me too.
in my office. We try to be reproducible at any time, and with plasma, it will be reproducible. But maybe we need to increase the sample of the trials to be
But
sure.
looks promising. Like
Yes,
I look
not
forward to
bad.
try. Yeah.
But it's not really new. It's like
I
since
know,
15
but
years
I don't
ago.
think we have in Brazil.
But I
look for-
encourage you, if you want to prove something in aesthetic, try to prove that something in there.
But it has consumable, no?
Sorry.
It has consumable. the nitrogen or something?
Consumables.
Yes,
Yeah.
you have the tips, but you have time to use it, no problem.
It's not one for
For-
one patient. It's
Is it
not like
painful?
If you make stacking, yes. But it depends. For rejuvenation, no. No, it's unnecessary because the setting for regeneration is 0.5 to 0.8 is unnecessary. And you have a lot for wrinkle or for sagging bag. It's not
Oh, really?
unnecessary. But for clinical indication, you increase the procedure. And for actinic keratosis 3, you need local anesthesia. For 1 and 2 is okay. Patient is okay. It's the same like you do cryotherapy or laser CO2 for just 1 or 2
How
shots.
long have you been using this machine?
2 years.
2 years?
there's a question there.
Ah, okay.
Hello. One question more.
Yes, I'm Nalini from Thailand. Congratulations for the innovations that are easy to use and precise. In case that I have some patients that has a lot of actinic keratosis or even basal cells, even nodular type, and patient is far away, so they cannot come to see me. What I advise, another option is BEC5. Have you ever heard about that? It's Curaderm, so you can buy it by internet from UK. And that is from the eggplant. And I think I have 100% success rate.
Okay.
And sometimes people doesn't have to do the flap or something. That is one of the choice as well, but not promise and easy like this. But when you use such a thing, you need occlusions. And I did have a patient that have a lot of actinic, and he is not in Bangkok. So he loved it very much. That is
Okay.
it. Thank you.
For actinic keratosis, for dyskeratosis, I'm totally agree. For active acne, it works very well. It's very interesting. Don't forget, it's not only a thermal effect. You have a wavelength. We evaluate the wavelength is from 300 until 800 nanometers. That is so interesting because it's like an IPL, not so far. So you have induce, so you have a target. You have absorption by the target inside the skin. But now for BCC is quite different. You know, for BCC, we love to make a diagnostic by PDT. Before we treat by PDT, just to see where is the problematic. And you know, with LCOCT is very, very interesting because it's a digital biopsy, and we confirm that some patients have a lot of BCC, but they're so small. But some BCC disappear alone. So with retinoid, with sun cream, sometimes BCC, small one, can disappear. Auto-involution.
Yeah. That is, and when you do with the cream, you occlude, BEC5 Curaderm, occlude, and the lesion will be oozing and bigger than the surface size, because under the skin, the lesion is more expand. So, and it eliminates through skin. That is one of the good things. But you see, if you do like an innovations device, it's exactly, you can see right away. But this is you need patient to do at home. Thank you.
Thank you.
We have one more question for you.
Not to be
Dr.
late.
Cartier.
You are the timekeeper. Huh?
Yeah. Thank you for your inspiring lecture. We know the plasma technology is very versatile. And from the paper, we can know the plasma can use to treat the drug delivery or chronic wound healing or treat the acne or some infectious disease. Can we use this modality, the Neogen, to do this treatment? Thank you.
Yes, you can. You buy one and you make a test. Easy.
That was next year.
Yes.
Come to
yes,
present.
Yes, you can.
Thank
Thank
you.
you very much for that excellent presentation, Dr. Yu. So the next speaker will talk on a human in vivo platform for evaluating skin regeneration after MLA-focused picosecond laser-induced optical breakdown. Dr. Lin Yun Nan.
Thank you, moderators. And I'm Dr. Lin from Taiwan. Today, this presentation shows why and how my proof of concept platform was established. Oh, okay. And I use MLA focus picosecond laser-induced optical breakdown as an intervention to evaluate skin regeneration. And my goal is to offer a fresh and practical perspective, simple enough to use clinically, helping answer one very practical question: which cream actually works better for this patient? And this is my disclosure and biography. And every company claims their cream works in my clinic, and manufacturers genuinely think it does. But the real question facing clinicians is which cream actually works for this patient after this specific treatment. Which agent should be recommended? That's exactly what this talk tried to answer. Oh, sorry. Regeneration is inseparable from initiating inflammation, but here is the clinical dilemma. Controlled inflammation drives healing, yet excessive inflammation leads to prolonged downtime. And in Asia, especially Taiwan, skin, especially post-inflammatory hyperpigmentation, is the most fearful adverse event. To boost the treatment result, the market is flooded with topical products, claiming to enhance post-procedural recovery. And the problem, everyone, is different. And a reliable, standardized way to objectively compare them is still lacking. In this study, MLA focused laser-induced optical breakdown, LIOB, is used as a controlled regeneration intervention, which creates dermal cavitation without damaging the epidermis. This produces a reproducible inflammatory and repair response, providing a standardized environment to test different topical agents. Clinically, the post-treatment response follows a predictable sequence. First, micro-injury triggers the repair cascade. Second, vessel dilatation increases local blood flow, producing the transient erythema visible here under white light microscopy. Third, fibroblast activation initiates collagen remodeling. And the goal in this study is to create a standardized, producible human regeneration model that allows objective head-to-head evaluation of topical therapies, assessing their effects on inflammation, healing, kinetics, and tissue remodeling. This is my treatment protocol. I use Picocare 450 at 1064 nanometer as was used for this protocol. Parameters were set to 2.1 joule per centimeter square, 6 millimeter spot size, 1 Hz with 5 pulses delivered. On each subject, 1 control site and 4 test sites were designed. Labeled test number 1 through 4, allowing within subject comparison. The 4 agents tests were 3 herbal-based formulations, which is special in Taiwan, and 1 beta-glucan with hyaluronic acid combination. This design controls for individual skin variability. And as a dressing method, after treatment, each test site receives a different topical agent, followed by occlusive dressing to ensure consistent absorption. The control site receives no active agent. And for outcome assessment, 3 spectrum skin analysis devices were employed. White light captures epidermal surface detail. Polarized light reveals mid-dermal structures, particular vascular changes and pigmentation, which is critical for tracking inflammation. UV light detects fluence, helping identify abnormal secretion or early infection. Additionally, a second device quantifies brightness, moisture, sebum level, and elasticity, providing multi-dimensional objective data at long-term follow-up to evaluate the rejuvenation result. Here, the baseline information response is visible under polarized light with erythema and vascular dilatation at the LIOB site. Laser-induced epidermal peeling and increased site sensitivity are common transient post-treatment reaction, as we can see over here. Okay, it's not working. And at 1 week follow-up, the 3 spectrum image clearly differentiate the healing trajectories across the 5 sites. Even at this early stage, difference in residual radiance and surface texture among the test group are already appreciable. Okay, so can I use the mouse? No. Okay. Can I use this to?
Big one. Like this.
Oh, okay. Thank you. As you can see here, the epidermal peeling, especially in test number 1, we can see he had uncontrollable inflammation after treatment. And in test number 2, we can see he had a better result to prevent post-treatment epidermal peeling, and skin sensitivity is decreased. At 7 months, the whiteness difference score narrowed to just 1 unit across all test sites. And we can see here, it's barely visible, yes. And this is exactly the kind of head-to-head comparison that's difficult to achieve with conventional method. And why this is a paradigm shift? Traditionally, before prescribing a topical agent, the available data comes from animal or in vitro system provided by companies. With limited clinical relevance for this specific patient, the LIBO platform works under practical clinical conditions, and this is safe, precise, and highly reproducible. The biological responses are real-world, not simulated. And the implications are broad. This concept enables evidence-based validation of skincare products after they reach the market, giving clinicians a reliable basis to choose the right topical agent. And this is my take-home message. To close, MLA-induced LIOB offers a proof of concept, standardized human-based regeneration model. It enables live objective evaluation of post-treatment inflammation. It identifies topical agents that strike the right balance between inflammation and regeneration in individuals, and ultimately it supports evidence-based optimization of post-procedure care. Thank you.
Thank you very much.
Thank you.
So, any question from the floor?
Yes. Make biopsy or by OCT to really see what happened below the skin, because you have only a clinical view with your super dermoscopy, yes. But to see really and to evaluate what happened below the skin, it could be interesting. On the time, it's just 1 week, you say that the follow-up is 1 week after, so it's very short.
Yes, but because...
But it is normal, because if you do the same picture 1 month after, you cannot see anything.
Oh, yes. So I have 7 months follow-up.
Ah, okay.
Yeah. And I focus on information post-procedure. So the most prominent result is on day 7. Yes. And I use two devices. And the first device is to see the topical reaction or epidermal dermis reaction after treatment. Yeah, I think if I have some device to evaluate more detailed or histology result without causing any damage to patient, I will buy.
Yes, because you know, if you have a LCOCT, it's not a biopsy. You can see because you use a picosecond from one take. One take. Your picosecond.
Picosecond.
From one take. One take. Laboratory. The brand.
Oh, Picosure. No. Yeah, Picocare.
Picocare, okay, Picocare. You can see with OCT or LCOCT the vacuolization of the keratinocyte. So you can have some information about what's happened below the skin epidermis about the keratinocyte, or maybe you can you can see how is the epidermis. You know, we know that if you make a stacking with a pico laser, you can induce, increase the size of the epidermis in the future. So you can prove that you induce some remodeling of collagen remodeling or epidermic remodeling. So it will be more interesting.
Yeah, thank you for your great idea. And my aim is to prevent and to smooth the post-treatment result. But I do not think that Picocare is not effective. It's effective.
Efficient.
Sure, but I want to prevent the post-inflammation hyperpigmentation.
Okay.
So the topical agent is only topical.
Okay.
It did not go into dermis in this case. Because LIB-OOB did not penetrate epidermis. It focused on dermis. So if this topical agent is effective, it will smooth the inflammation after treatment. So I think these two devices is quite enough for me to evaluate post-procedural information. Because I am not looking down deep to dermis. I just look what happened or in the epidermis.
Okay, thank you.
Thank you.
Thank you. No question? Lunchtime? Coffee break? As you want.
Thank you.
Okay, thank you.
Thank you. Yeah, picture.
Thank you very much.